Great. So I think we'll make a start. So good evening, everyone. Welcome to our second Hope to Sleep webinar. My name is Tim. I'm Hope to Sleep's Vice Chairman, and I'm also going to be your moderator for tonight's event. So just to reassure you that we can't see or hear you, if you'd like to ask a question to any of our presenters, then please use the question and answer function at the bottom of your screen, and we'll do our very best to get through them. If you have emailed a question to the charity, please can you copy and paste it into the Q&A section, so we definitely cover it this evening. So we've got 3 speakers tonight. So we'll be starting with Dr. Manuel, who is Respiratory Sleep and Ventilation Consultant at Aintree Hospital. So Ari is also medical advisor to the charity, and he's going to be telling us about his roles and then also answering questions that you have. We'll then move on to Sam Backway. So Sam is a specialist sleep nurse at Great Western Hospital, and she's also the charity's chairman. So Sam's going to spend 10 to 15 minutes explaining the difference between different therapy devices, which I know can be a maze. So hopefully by the end of the webinar, you'll know your VPAP from your BiPAP and your CPAP from your APAP. And then lastly, we go on to Hope2Sleep Founder and CEO Kath Hope, who's going to spend about 20 minutes or so on dry mouth, the causes for it, but also the products that can help relieve the symptoms. We'll then wrap up with a Q&A session for as long as we can. There were a lot of questions last time, and we aim to be wrapped up by about 9:30 at the very latest. So without further ado, I'd like to pass you over to Dr. Ari Manuel.
So thank you so much for allowing me to speak today. I'm Ari. I'm one of the medical advisors to this fantastic charity. So I met Kath a few years ago now, probably about 3 to 4 years ago. I work up in Liverpool, and she sort of, if you draw a straight line, they're sort of the northeast is her territory. But we've had a lot of interactions, and we always recommend Hope2Sleep to help with our patients, and a real point of really good support, practical support, and background reading for our patients. So we really we work very closely with Hope2Sleep at Liverpool. We're probably one of the biggest centres that provide sleep apnea support in the UK. Certainly one of the biggest in the Northwest. And so it's always a pleasure to work with Kath on a number of things, and we always have a good natter. And we're texting each other from time to time, gossiping most of the time about the world of sleep apnea. I can see her laughing on the Zoom. So we're often gossiping about lots of rumours that sort of circulate in the world of sleep apnea. So first of all, I'd like to thank everyone for filling in the questionnaire. Thank you very much for taking your time to fill that in. It was really useful for me. The reason that we or I asked you to do that is I am sort of part of some of the new NICE guidelines that are coming up in sleep apnea. So as some of you may or may not know, there is an update of the sleep apnea guidelines from NICE. It was due to be released at the end of last year, but due to COVID-19 has been delayed, and unfortunately is likely to be delayed from April, I think was the first exposure of what has been written, so slightly later on in the year. So there is another NICE guideline coming out this year, which I'm involved in fact, in the next week, which is looking at people who have residual sleepiness. So who have sleep apnea, are treated effectively with CPAP therapy, but are still sleepy. So that's defined as residual tiredness or sleepiness. And there are a couple of medications that are being introduced potentially to the UK. They've been introduced to Germany and United States currently, and they're coming potentially to the UK, where people in this group, and there's potentially about 20% of people who fall into that category, can take these medications, and then they get a increased amount of daytime improvement, in their daytime wakefulness. So this is quite an exciting area, and really will be revolutionary potentially to sleep services in the UK. However, the key thing is we can't be concentrating on that component of those things until we know that services within the UK are equal. So a big problem at the moment in the UK is the availability of sleep screening, treatment of patients for sleep apnea. So essentially the equality across the country is not very equal, and it's very patchy. And I'm sure that lots of you come and contact the charity to see if they can offer some help, but certainly that is a big problem, and certainly your questionnaire has reflected that the experiences amongst you sort of really vary wildly. Many people are waiting months and even up to a year to get treated, and it's often very difficult to in fact get a initial sleep study by your GP. So certainly I know in the Northwest, so in Liverpool and the Wirral at the moment, that patients who have good histories that go to their GP for sleep apnea are asked to go and see a health coach initially. So they're not allowed to have a sleep study, but have to go and discuss with someone about lifestyle advice around losing weight. So certainly that that presents itself a lot of difficulties, as there are a lot of issues around not treating sleep apnea promptly, quality of life being a big issue, not only for the patient, but for the partner. Then there are complications around people's occupation. So obviously a lot of people think about professional drivers as being a key component, but often we have patients, certainly I see a lot of patients in the area I cover, that are put on disciplinaries or put on various issues around their work because they're shown to be performing not as well as they can do because they're late for work or sleeping in work. And this is usually or can be due to untreated sleep apnea. So it's very important to treat it promptly. And then obviously you have the sort of very serious complications such as the cardiovascular risk around high blood pressure and stroke and heart attack, as well as other co-related issues such as diabetes. So it's very important that I think there is a universal sort of approach in the UK, so everyone is equally allowed to have a sleep study and has opportunity to get CPAP therapy or be treated for it. And certainly I very much support this charity and the work that these guys do, because I think they're really important in trying to improve that for everyone in the UK, and that's really important. So I guess, so Kath texted me a bit before this talk to say, to talk a little bit about upper airway resistance syndrome. So I can talk, I guess, around what I can talk about the upper airway resistance syndrome. So essentially that is, sleep apnea is defined by an ODI, so that's an oxygen desaturation index, or an AHI usually, which is an apnea hypopnea index of greater than 5 being mild, greater than 15 being moderate, and greater than 30 being defined as severe. The NICE guidelines currently say that for mild sleep apnea, so an ODI, let's say between 5 and 15, you have a choice of treatments, either CPAP or conservative measures, which are essentially weight loss, jaw advancement devices, so non-CPAP therapies, or positional devices as they come to the market. Now, upper airway resistant patients often do not have an AHI or ODI recorded on a sleep study, so they're often around below 5. And in many areas in the UK, these patients will then not qualify for any treatment for CPAP therapy. Even patients with a 5 to 15 rate or score often struggle to get CPAP therapy around the UK, and that's difficult, isn't it, as it is. But with upper airway resistance, often patients don't get treatment, even though they're certainly symptomatic. So they'll often have symptoms very much in keeping with sleep apnea, and over the course of time will almost certainly develop more significant sleep apnea, so more disruption as they go from upper airway resistance on a spectrum to develop more severe, mild, then moderate, then severe sleep apnea. So perhaps treating them sooner would be better, but from essentially a financial perspective, it's often very difficult to get treated. So a couple of things to, if you're in that group and you're struggling, things to consider, that there was a very large trial called the MERGE study that showed that treating people with mild sleep apnea, even with AHIs or ODIs down at 5, showed an increase in their quality of life. So there's now going to be certainly a bigger push towards treating people even with very low numbers in terms of their sleep apnea studies. So these are all people that are pre-treatment. In terms of if you're stuck in that group of upper airway resistance, so you've had tests and they haven't shown anything, I think the key thing to do is make sure that wherever you're getting your test done on the NHS, it's the appropriate test. So often an oximeter will underscore your sleep apnea, and often not report the amount of sleep apnea you've got, so often will be reported as normal. So it's important that you don't simply have an oximeter. Ourselves at Liverpool have several devices. We usually use something called an Apnea Link, which is slightly more advanced oximeter, which also looks at position and looks at central sleep apnea, which can also be present. And then I think it's very important, if there's any question around whether you think you're at this upper airway resistance or very mild sleep apnea end of the spectrum, to get something called a multi-channel sleep study. Now, they aren't very common on the NHS, but they are available, and essentially they look at both the ODI, AHI, and many of the devices look at leg movements. That they also give us a lot more data around heart rate variability and allow us to make a diagnosis that can convince people to then get CPAP therapy. So it's important, if you're in that group of having upper airway resistance syndrome, that you're having the right testing to make sure that your physiology at night is repeated. Now, the MERGE study also showed that on one night, there is a large night-to-night variability on sleep studies. So when I started my practice, probably perhaps 15 years ago or 10 to 15 years ago, we'd often just do one sleep study, and that was it really. But from this MERGE study that came out in the last year, it has really sort of changed my practice, that many people can have an almost normal sleep study, and then if we repeat the study, there can be some evidence of mild sleep apnea. So often that's another option to look at, to see if there's any sort of change from day to day. Other techniques that you can use to help diagnose. So sometimes we look at actigraphy. So that's a wristwatch, a wrist device that looks at movement and equates movement to sleep disorders. So that's somewhat another way to characterize your sleep over a 2-week period with a sleep diary. And again, although we can't diagnose sleep apnea from that, it gives us a feel to see or look at sleep disruption, and that with a sleep study helps us try to make a diagnosis. So I think there are lots of options for people now in terms of trying to diagnose sleep apnea, especially when they're told from simple oximetry, that then they're inverted commas normal. So it's important to try to get as many tests, or try to get the right test for you to help diagnose. So that's my sort of little talk. I don't know if you want me to go straight onto the questions, which I'm happy to do so.
Thanks, Ari. Lots of information there. The questions have been coming in whilst you've been speaking. There's a few here which maybe I'll read out, and then maybe if you have time to maybe type some answers to the others whilst Sam and Kath are speaking. Let's go up to the top. So do you have any tips on how to manage a CPAP machine with chronic rhinitis?
So chronic rhinitis, so that's inflammation of the lining of the nose, can sometimes affect the sinuses. So from the kind of aspects to think about are, so what we like to do is try to make sure you're on the lowest pressure that treats the sleep apnea, to therefore reduce the amount of inflammation. So it's important to do a sleep study and multiple sleep study recordings on the CPAP device to make sure that's controlled. Secondly, it's making sure the humidification is right, so it's not too high or too low, so it doesn't increase inflammation. And then in terms of face mask devices, it's looking at whether nose is the right or wrong thing, or if they have a full face mask, because nose may not be ideal because it's forcing air through the nose and making things worse. In terms of direct treatment to the nose, then that would be a steroid spray or a ipratropium spray. So we often suggest, so there's lots of sprays and also regular saline washes. So those are to really improve nasal hygiene, really. So you're cleaning out your nose, treating the nose with steroids and medication. If you have asthma, so often people have asthma or allergy, and in hay fever season, taking a non-sedating antihistamine such as fexofenadine is very useful. That reduces the inflammation, and a drug such as Montelukast, if your GP agrees with that, will also reduce nasal inflammation. So there's lots of options. Often people who have chronic rhinitis often will have reflux disease, so treating reflux disease with conservative measures, so sitting people up and treating them with either a H2 antagonist or a protein pump inhibitor will also help. So lots of things you can think about.
Cool, thank you. Another question here from John. Can the use of a CPAP machine exacerbate the symptoms of GERD or a hiatus hernia?
So yes, they can do. So if air is going into the stomach, you're going to get aerophagia, which is likely, you're going to get two types of symptoms. The top end, you're going to get reflux and heartburn, and the bottom end, you're going to get flatulence and sort of a change in bowel habit. So lots of people get irritable bowel symptoms. You can treat that with medication. So again, it's similar to the chronic rhinitis. It's trying to get the right pressure in the interface, so you're not having too much pressure put down there. Then in terms of the upper end, it's things like PPIs and Gaviscon. You can try things like peppermint oil, charcoal in extreme settings can all help. Also think about taking probiotics to try to help with digestion, because you're pushing air into your gut, so changing things around.
Great. I have COPD and sleep apnea and was put on oxygen in October 2019 and used a CPAP machine. I've informed my sleep clinic, but they were not interested. Is there any guidelines for using oxygen with CPAP?
So it's a tricky one. So it depends if the oxygen's entrained into the machine or they're wearing the oxygen separately. I think it's important that the sleep unit is aware, because I think I would go back to them, because I think if you need, so traditionally the CPAP machine should increase your oxygen levels back to normal if the only disease you have is sleep apnea. However, if you have any other disease, so asthma, heart disease, COPD, you'll need supplementary oxygen or potentially need something else to help you, or bi-level ventilation, which I think Samantha's going to go on and talk about. So it may be that you need conversion from CPAP to bi-level ventilation because of that need of oxygen, i.e. you're under breathing as well as having sleep apnea. So it's probably important to go back. Plus, you can optimize your COPD treatment with inhalers and other treatments.
Cool, thank you. So is there a particular multi-channel sleep study that holds weight with NHS diagnosis and treatment of upper airway resistance syndrome?
Not specifically, so I'm not here to sponsor anything. We use Somnotouch devices. That's just the devices we use because they do our polysomnograms. You just have to have one that does multi-channel. There are, to be honest, if I'm truthful with you, there's not as many labs that do multi-channel studies. And certainly to get them at home is difficult, but you should try to seek out one that does that. And I think try not to be fobbed off with simple oximetry if you can. It's hard, it's easier said than done, because we get a lot of secondary referrals from lots of centres all around the country, and it happens a lot.
Cool. So do one more question before we move on to Samantha. One which comes in very frequently is to do with, if you lose significant weight, do you get rid of the sleep apnea?
It's complicated. All of us, as we get older, develop sleep apnea, but whether we develop sleep apnea syndrome, i.e. the sleepiness associated, is difficult to say, i.e. all of us with age, our upper tone, our throat muscles become weaker. So if we were to do it cross-sectionally, we'd find lots of people have sleep apnea. When you have surgery or just lose weight, you may lose the weight, but it sometimes doesn't come off the neck. So therefore you may still have sleep apnea. I usually talk to the person, repeat the study off treatment, and then I go back and talk to the patient and say, well, your sleep apnea has got this much better. Do you feel like you still need the therapy? And then we have a mature discussion about, and that's dependent on, you know, so if someone has just symptoms and they've gone away, then I say, fine, not using it's okay. But if they've got atrial fibrillation or high blood pressure or stroke risk, then they may still need to have it, even if they've lost weight. It's a sort of it's a gray area where you just have to talk to your consultant if you can. We try to offer, we have a consultant-led service in Liverpool, so we're pretty accessible for patients in some ways. In some ways we're not great as well. And I think that's a discussion you have to have with your clinician, whether it's physiologist, nurse, or consultant.
Cool, thank you very much. So I think what we'll do there is pass over to Sam, but please keep the questions coming in. Hopefully if Ari's able to stick around until the end, we can do some more questions. And also if Ari's maybe to type some answers to some of the ones that have come in, that would be fantastic. So I will now pass over to Sam.
Hi, thank you. Can you hear me? I've just
Yes.
shared my screen. Can you see the screen all right, Tim?
We can see your screen, yes.
Brilliant. Okay, right, thank you. So I've been asked to talk briefly about some of the different types of machines that we use to treat patients in the sleep and ventilation clinics. They often can cause a lot of confusion, and I know there have been numerous discussions on the page about the different types, and actually even there's issues with medical professionals that don't know the difference. So hopefully this will explain a little bit about the different types of machines. Oh, my next slide is not happening, Tim. Why is that?
Have you, oh, there we go.
I didn't press hard enough, I don't think. So obviously the first machine is the CPAP machine, and that stands for continuous positive airway pressure, which is a constant pressure of air, and it's continuously applied to the upper airway. This keeps the airway open so it doesn't collapse in sleep. Tim, sorry, this is moving on without me touching. What's happening? It's moving on. I'm not touching it. Can I stop sharing a minute?
It might have just been playing catch up. If you try doing it again.
And I'm sorry about this, guys. I don't want it to move too fast.
Technical difficulties.
How do I go back?
Okay, so
it's
you just use the left and right buttons on your keyboard.
Yeah, it's not going back.
If you go bottom left corner of your screen.
Yeah. Nothing. All I've got is my screen, and
oh, there you go. Can you see right the corner? There you go.
That
Can
one.
you try that one?
Right. So
and
hopefully it was.
Let's give that a go.
Sorry. Right. So yeah. So CPAP is continuous positive airway pressure. This is probably the most common machine that you're going to hear about and see in a sleep clinic. It applies a constant pressure of air, and this is continuously applied to the upper airway. Now, this pressure is set by the sleep clinic. So you have your sleep test, they decide how severe your sleep apnea is, and each clinic's slightly different how they work out the pressure. Some use an algorithm, some just give you a pressure. It's doing it again, Tim, I've not pressed it. Sorry, it's going too fast.
It might be. Are you still pressing?
No.
It might be because it was on like an automatic animation, maybe. Let's keep going and hope for the best.
I know, but it's moving too quickly when I can obviously do what it's saying on the screen, but I'll try my best. Okay, so it's a constant pressure that's set by your clinic. They decide what pressure you have. This keeps the airway open so your airway doesn't collapse in sleep. But the thing with CPAP is because the pressure is continuous, even if you were in a position where your airway was open, it's still going to blow a continuous pressure of air in. Each machine is slightly different depending on the manufacturer that you have. They all have their own way of working them. So sometimes you've got with like the Philips, you've got Dream Mapper app, so you can use the app to monitor your data from home, and ResMed have got a website. So each machine, each manufacturer is slightly different in the way they market and sell their devices, but very similar. They're all used to treat obstructive sleep apnea. And these are just some types of CPAP machines. There's obviously loads on the market, and I couldn't show all of them, so I'm just sort of using some basic ones that you might see, some old ones, some young ones. It's doing it again. it's off to APAP. APAP stands for automatic positive airway pressure, and this again is still a CPAP machine, and it's still going to give you a continuous pressure, but it automatically adjusts the pressure as you need it. It's got sensitive technology, and it looks at your breathing breath by breath, and it will automatically change it as you need it. So it's using sensitive algorithm therapy. Your breath is analysed breath by breath, and like I said, this will also sort of maximise the comfort that the machine will give you. And it's got low and high pressure ranges that this can be adjusted according to need. And again, this is what is done by your clinic. They set a low and a high pressure, and then this can be adjusted. Now, the auto machines look the same as the CPAP machines, which is why I think sometimes people get a little bit confused. And depending on the manufacturer, then obviously they write auto on there. It is moving a bit too fast again, sorry. So with the APAP machines, they are used to treat obstructive sleep apnea, and they can be used to treat upper airways resistance syndrome. Like Ari has mentioned, it's quite difficult to get a diagnosis of upper airways resistance syndrome, but we can use it for that. Some patients have different pressure needs during the night. So just go back, let's go. Oh, not liking it today. Some patients sleep differently at night. They might toss and turn. They might sleep on their back. Sometimes with nasal issues or allergies, this can cause you to have different pressure needs during the night. So an auto is quite important for that. And some clinics actually use the auto to determine what pressure they would set for a CPAP machine. So actually you would have a sleep study, and they would give you the auto machine, and you would have a trial of that machine for a while. You'd then go back to clinic, and they would actually determine what pressure you needed for a CPAP machine, and then they would change you over onto a CPAP machine. So but it really does depend on the clinic. Obviously, we don't all do that. And sometimes with patients, they also always go, we're going on to NIV. So NIV, non-invasive ventilation. So this is the bi-level devices. Now these deliver two pressures, one on inhalation and one on exhalation. So this is where you get the IPAP and the EPAP that you might hear about. And these are two pressures that again are set by your clinic. They're very complex machines. They have other settings and modes on them to make your breathing more comfortable. And they are more of a ventilator, and they are used in more complex health conditions. So you could use them for COPD, motor neurons disease, obesity hyperventilation syndrome, scoliosis, just to name a few. But they also can be used for obstructive sleep apnea that is maybe difficult to treat, or if it's ineffective, or occasionally if you really can't get hold, you really can't get used to the NIV machine, they can CPAP, they can use it. Now NIV can be very confusing. You may hear terms like BiPAP, which is a Philips machine, Trilogy, which is also a Philips machine, NIPI, AirCurve, Stella, and VPAP. Now these are all NIV machines, but these are the names of the NIV machines. A lot of people use BiPAP as NIV, but as you can see, it's actually a trade name for Philips. So it's actually like calling a Dyson a Hoover. So if you're saying I'm going to go and hoover the stairs with your Dyson, you're actually not doing that. But this is where it gets confusing with patients, because they say I'm on BiPAP, when actually they are on BiPAP. They're on a bi-level pressure airway support machine, but they're actually maybe on a VPAP, which is a ResMed machine. So it is, but when you go into hospital, actually most doctors and nurses would know. If you say I'm on BiPAP, they know you're on a ventilator, you'd hope that they should do. But it is quite confusing, and you see, and this is just a few manufacturers. There's obviously a lot more that make NIV machines, so it can be very, very confusing. And again, here's a few NIV machines, and again, because they look very similar to CPAP machines, this is where the confusion can rise. And actually also in hospital, they're different again. Now, there's also a machine called an ASV. Now, I am not going to talk too much about this because it is quite a complicated machine, but it's adaptive servo ventilation. It's a new technology. It tracks your breathing, and responds with extra pressure if you need it. It's mainly used for patients with complex central sleep apnea, and periodic breathing. They're very expensive, and there are only certain patients that they would use them for. There's certain categories of patients they do not recommend it for. So basically, a full assessment and discussion needs to be made from a specialist with very careful monitoring. Now, Kath has also asked me to talk about CPAP and COVID-19 that we use in hospital, because obviously I was redeployed onto a COVID ward, and we've had a lot of discussions on the page about COVID and CPAP, and it caused a lot of confusion, and you'll see that it's actually not the same. So why would we use CPAP in COVID patients? So at the beginning of the pandemic, there was guidelines that came in with clinical pathways, and the patient would follow this pathway. So not every patient would need CPAP, but if they did need CPAP, then obviously this is what we would do. So COVID can lead to COVID-19 pneumonia, severe acute respiratory syndrome, which can cause the lungs to swell, and the small air sacs, the alveoli, can fill with fluid and get congested. This interferes with the transfer of oxygen. They get coughing and shortness of breath. And in some cases, patients just needed oxygen, some steroids, and maybe some antibiotics, and obviously rest. And in hospital, they were doing a recovery trial and actually found that dexamethasone was proven to reduce deaths by 1/3. So it's actually now a recommended treatment by the NHS. It's not part of the recovery trial anymore. It's actually a treatment. Obviously, there's other treatments and drugs, etc., in the recovery trial. And obviously, if anything comes out of that, we will hear about it. But there's some really good research going on that recovery trial. So the role of CPAP, it's actually a well-established technique for improving oxygenation in patients with respiratory failure. And it's actually been used for many, many years, and it's not the types of machines you see at home. So this device you can see on the screen is actually the Ventura, which was reverse engineered by, I don't know if you remember seeing it in the news, by UCL, University College of London, and the Mercedes Formula One team, I think it was. So they reversed engineered a machine that had already been in use. So it had more oxygen capabilities, more flow, and they obviously started using this. But some hospitals did not have access to the Ventura device. So we had to use maybe our own NIV devices in CPAP mode, or even we were using domiciliary devices. So these were the types of machines that you would use at home. And obviously we would use them with oxygen. So the role of the CPAP is to prevent a patient needing intensive care and invasive medical ventilation. We want to keep these patients out of intensive care. So we'd use it with really high flows of oxygen. It forces the oxygen into the lungs, pushes any fluid out, and it keeps the airways open, allowing the oxygen obviously to pass through and able to help the patient. And it also allows the patient to recover from this inflammatory effect on the lungs, and it can also prevent lung damage. Due to the aerosol generating procedure that CPAP does, it was obviously classed as this, and it pushes droplets further into the air. So we had to use a certain room and certain equipment. So ideally, they should be nursed in a negative pressure room. Not many hospitals have them, we didn't. So if a negative pressure room wasn't available, we had to have a neutral room or a simple side room with ventilation, which sometimes meant just opening a window. And if there was no side rooms, or that all the side rooms were full, which is what we got to in our hospital, then we'd start cohorting all these patients in a bay. And in my hospital, we adapted the wards by having these blue COVID-19 areas. So we completely moved them. We had separate entrances. We had new doors fitted. We had new rooms done. So it, basically a lot of hospitals completely adapted them. You have to have special equipment while you're using your CPAP in hospital. So you had to have a non-vented full face mask, or in some cases, because we didn't have non-vented, we had to tape the vents. And then we had to add some antiviral and bacterial filters between the mask. We had to put in an exhalation port, which you can see on the picture just underneath the bacterial filter. So the air would pass through the filter, hopefully catch some of the virus, and then you'd breathe out through the exhalation port, so allowing it to be a lot safer for the patients and for the staff. These filters had to be changed every 24 hours. And in the first wave, we actually ran out of these filters in the hospital, and we were having to change them every few days, and I think at even one point they were doing them weekly. So it got really quite dire. At the moment, the second wave, been fine, managed to get hold of them. And then we had to wear full PPE. So this is me wearing my full level 3 PPE. So we had to wear an FFP3 mask, which had to be fit tested, and you had to be fit tested for every single mask. So if one went out or you ran out, then you were given another mask, which you had to be fit tested for. So I was fit tested 3 times for different masks. Long sleeve waterproof gown and 2 pairs of gloves, and then you had to have a visor or goggles, and you had to wear this all the time that you were using CPAP. You were with a patient on CPAP. And for some patients, when they were really poorly, they were on CPAP nearly 24 hours a day. So, you know, the nurses, the doctors, anyone who came into contact with that patient, physio, had to wear this full level PPE at all times, even in that really hot weather that we had. Oh, sorry. So, care of patient. Oh, doesn't like me. A patient on CPAP might need to wear this all day and all night. Some breaks if they were able for eating and drinking and mouth care. Oxygen was very drying, but at the beginning we weren't allowed to use humidifiers. It wasn't advised because of this aerosol generating. So we had to do regular mouth care with oral gels and drinks. And obviously some patients did require intravenous fluids. We sometimes had to put dressings on their nose and around their face to relieve pressure areas, because obviously you wear yours at home for maybe 7 or 8 hours a night. You've got lovely comfortable masks. We're using masks that, you know, are really tight, and they're wearing them for 24 hours. We're monitoring their oxygen levels 24/7, regular observations. They're not getting a lot of rest. We're proning them, we're lining them on their front regularly for long periods of time. Some patients required actually morphine to reduce the work of breathing and actually help them tolerate the CPAP a lot better, so they also could rest and use it. No, it's not going. Oh. And I would just like to say a massive thank you to all of you guys, the patients. You have really supported us with your patience and your understanding. I've even had phone calls from patients offering me their CPAP machines because they wanted to make sure the hospital patients and the COVID patients were well treated, and they were happy to give up their CPAPs. But the support we've had from the patients. So I got together with a couple of the guys that are on the page. These are all clinical nurses. So there's Yvonne there and Fran, and they've done their own little thank yous for you, just to say thank you so much. And, you know, we really appreciate all the support that you've given us. And then there's just a couple more there. I did email quite a lot of the clinics, but I think they were busy, so I didn't get many photos. But there's Trish as well from up in Scotland, and there's Joe, who's my colleague, who is obviously just saying thank you. So thank you. Sorry for the glitches, don't know what happened there.
No need to apologise. I wonder if some of your keyboard keys are a bit stuck, maybe. I'm not sure what else it could be.
I tested this before I came on and it worked perfectly. So why it was doing that,
it's always the way.
Hopefully it just seemed a bit rushed, but hopefully I got through my points.
Not at all. Anyway, thank you for the clarification on the different types of machines and also the fantastic insight into how you guys are managing patients on the front line. So I was going to do some questions, but Ari's just done an incredible job, and he's just typing away. And any questions you throw at him, he's answering straight away. So thank you so much, Ari. Keep the questions coming whilst we've got him online. So I will now pass over to Kath, who's going to talk about dry mouth.
There you go. Okay, so what do I do first? Let's take a little sip. Well, I expected some questions, I wasn't quite ready there. So yes, dry mouth, or in its medical term, xerostomia. And it's not something that we want to be putting up with. You know, we have enough problems, you know, wearing our masks, but to, you know, have to be disturbed during the night by dry mouth, and this is people who use oral mandibular devices as well, because it's, they keep it still. We're not going to have any problems because I've got Natalie on my right hand side doing man, but she just decided to move me over to the right. Yeah, so because obviously a dry mouth, you know, does lead to lots of problems: bad breath, oral thrush, dried and cracked lips. But even worse is it leads to tooth decay and gum disease. And this is why dentists, you know, even people who aren't on CPAP or ventilation, you know, are constantly seeing problems in their own practice that are actually caused through dry mouth. Many people who are using masks assume it's the mask that is causing the teeth and gum problems. They often, you know, post in the group, are your teeth moving with these masks? Now, yeah, that can happen. With an ill-fitting mask, it definitely can happen, but the majority of cases, it's actually the dry mouth, causing the gums to recede, causing the teeth to be loose. And it's the dry mouth, you know, it's going to the root of the problem, and that's why it's so important. So, but obviously, even people that aren't using the equipment we're having to use to go to sleep, you know, struggle from dry mouth for many other reasons. Now, there are lots of other causes apart from the dry air on the CPAP machines and the ventilators. Sjogren's, have I said it right? Diabetes, chemotherapy, radiotherapy in cancer patients, smoking, mouth breathing, alcohol, spicy and salty food, alcohol-based mouthwashes. People don't always, you know, think of that. They're actually, you know, getting their mouth, thinking they're doing great hygiene in the mouth, but actually they're causing a dry mouth with some of them. Toothpaste with foaming agents is another one. Nothing that we like to think better, seeing lots and lots of suds, even in the sink, you know, all those suds, but in actual fact, that can actually cause you a dry mouth. Dehydration. Snoring, we all know about that one. Anxiety, how many times, you know, are you doing something like this even and your mouth suddenly goes dry? Then of course you get the other problem, medications, things like antidepressants, diuretics, blood pressure medication, antihistamines. In fact, it's really any medication that you're on, it's actually worth checking the patient leaflet for anything that you regularly have to take and just see if one of the side effects is dry mouth. Now, obviously, you can't stop these things because you need them, most of the things in the list. So you've got to look to other avenues to get to the root and try and get rid of that dry mouth. But if you add any of the lists that I've just mentioned there, if you add any of that to CPAP and ventilation, you can see why you've got a huge problem. So the dry mouth was probably there before you put the, you know, before you ever was diagnosed with sleep apnea, and because of mouth breathing in itself, which a lot of obstructive sleep apnea people do. But so you can see why, you know, we have a tougher time than a lot of people. You know, we have a lot of people in our group with Sjögren's. There's a lot of people, you know, there are actually links with sleep apnea and Sjögren's. And obviously it's 10 times worse for those people. So that's why, you know, this article is about this, because we're hearing a real lot about it. And listen to this. As I was preparing this talk, I came across, and you can Google it later, stay with us for now, Google mask mouth. Now, it was very, very interesting that I came across that, because this is one of the many things, you know, that seems to be happening with this pandemic that we're in. And apparently dentists, they're seeing more cases, now they're starting to open, of bad breath, tooth decay and gum disease since the use of face coverings, which we obviously need. Now, obviously, this doesn't mean don't wear your face covering, because any of us would rather have dry mouth than COVID-19. And especially as until you get it, you don't know if you are one of the unlucky ones. But it is something to bear in mind. It's thought that mask mouth, if it is ever going to be a correct term, I think at the moment it's a loose term dentists are talking about, but it's thought it's going to be worse for people who need to use the face coverings for a long time, long period, rather than just someone like me who, well, not at the moment because we're in lockdown, but, you know, may pop to the shops, you know, or, you know, maybe a couple of hours having a walk. But I mean, as you've seen, what Samantha and the other people on the front line are having to use, those are very, very tight fitting masks that they can't take off, that they can't stop and have a drink even, because the whole thing needs changing. So, you know, even those people who are there working their butts off to help people during this time in the hospitals, and not even just on the COVID wards, they need to be thinking as well, you know, what can I do for my dry mouth? Because it really, really is important. But I just thought that was quite interesting, because it was actually just something else I was looking up that I came across it, and it never dawned on me, but it's made me think now myself. Now, it's always going to be easier to help ourselves with a dry mouth during the day, but it isn't so easy at night, because we can't continuously sip water or chew gum. Thankfully, there are some products that can help us, because not only that, dry mouth, as we've already said, well, I've already said, I should say, you know, what, you know, the problems it can cause. It's actually also going to cause disturbed sleep, and that's the last thing we want. We've already got the masks on, you know, got used to the noise, got our fits sorted, stop the machine making rude noises and the masks, and then we get woken up with dry mouth instead. So we've got to stop that. So for people who do need the machines, obviously, you know, there are humidifiers which go to sleep. There are the humidifiers, and you may have seen some on Samantha's pictures attached to the machines. You can see on our own website, we do sell a few humidifiers for the machines that we sell. But sometimes people don't realise, they don't actually always know humidifiers exist. The clinics, you know, most clinics will give you one if you struggle with dry mouth. Some clinics give them anyway. You know, but just remember that there is that option if you are struggling with a dry mouth. Now, there can be a few problems that crop up with humidifiers, but I don't want to go into that today, because that is a whole website article that I've actually been writing recently on our new website, which none of you have seen yet, which is going to be even better than the one we've got, because all the articles will be separate rather than on one page. But you will be able to see problems sleeping with CPAP and non-invasive ventilation masks, is it? Yeah. On our existing website, and have a look on that. It's under the help section, and you can read more about things like mask leaks, about humidification, and so on. So they're not without the problems by any means. So I don't want to go into depth about it. But the tips I do need to mention is simple tips, such as the humidification settings can make such a big difference. Now, many machines, and a lot of people don't know this, and in our group, those of probably a lot of you on here today are from our private Facebook group, and it's a very active group, as you all know, and we do get repeat questions. And one of the things is, I've got it on setting 5, but I'm waking up and it hasn't hardly moved. I think it's broken. No, it hasn't. Well, in most cases, it hasn't, because what it is they've got a default setting. So, example, on Philips Respironics machines, it's called adaptive humidification. That is the default. Now, when people purchase machines from us and we do the settings before they're sent, the first thing we do is take that off. Sorry, Philips, if anyone's listening, but it's adaptive humidification doesn't always get it right. You may be fine, but there's a huge percentage of us who do need to change that setting so that it's off the adaptive and onto fixed. And it's the same with the ResMed machines. That the default setting is called automatic climate control, which is great if it works fine. And I'm not knocking this, by the way, because I know you guys had, have done a fabulous job on these machines. But you've got to bear in mind that these machines are all over the world. And so there's certain parts of the world that have a really, really high humidity. And then there's other parts that don't. Our humidity in the UK isn't too bad, except when we get rare times when we get high temperatures, and then we do go hot and humid. But a lot of the time, it does seem to work better if we decide, how much humidification that we want to get, because I can promise you, as those will verify from our group, when we get somebody to change that simple setting, they'll come back the next day and go, "You're right, it's okay now," or "Oh heck, I got drowned last night because they changed to fix but didn't adjust it." So also don't forget, that the seasons change and people forget that the humidification, they might have, example at the moment, number 3. As it's getting a bit milder, you might want to turn it down to number 2. Now, Fisher & Paykel, by the way, they're renowned for being the leaders in humidification. I haven't actually used one of their machines for a few years. But when I did, and it's actually what I started on, way back when humidification wasn't as much as common in all the other brands, but Fisher & Paykel's was really good. I actually can't remember having any problems. But if there is somebody who's using a Fisher & Paykel and does know if there's a setting that needs changing, just pop that in the comments to help other people, because I can't answer that one tonight. So, like I've already said, remember to increase it. My gopher, John, who's in the front room keeping the dogs quiet, he always fills my humidifier up, and he's the one who gets it in the neck when he goes over that line, because that line means he's overfilled it and the noises start and the water comes. But he actually said to me a few nights ago, your water, it's disappearing every morning. Yeah, because the seasons change and I needed to adjust it a little bit. So just remember, and that is not something your clinic needs to do. That's something that we all have access to give ourselves more humidification or lower it. So you can see if you're not sure what I'm talking about, you can have a look on our website, just type in a search, CPAP humidifier, and you'll see what I mean. So there are lots of other things that help all of us with dry mouth at night time, and this is whether or not you're using a mask or not. You don't have to be a mask user to use these things, but I can promise you, if you go to our website and you put a type in Xylemelt's discs, have I got some here? Yes. Can you see it? XYL. Oh, do you want to pop it in the group? Yeah. Xylemelt's, because people say it wrong. It's an X. Think of the xylophone, but it's Xylemelt's. And I can honestly say they are the best solution in most cases. Like any other product, you'll never, ever get 100% success. So there's always going to be a small minority of people that don't. So, and you read those as well. You can read that feedback on the website. But they really are the best solution because they work with our masks. And in actual fact, if you get it in the right place, the mask can often keep it in place if it did come unstuck. I've noticed that. And they work well during the day, but I'm specifically talking here about nighttime use. Now, the reason why they're so good is, number one, they stick to the gum. They work during the night whilst we're asleep to give us constant relief from the dry mouth for many hours. It obviously varies from person to person, but it's usually for around 6 hours in most people. In fact, sometimes, when you wake up and you think, is it time to get up? And I put my tongue there, I think, no Xylemelt. It's probably time to get up. Or if I put my tongue there and there's half a Xylemelt, I think, no, I'm only halfway through the night. Like I say, it will vary from person to person of the amount of saliva you have got in your mouth. Some people have a lot more problem than others. Now, 2 days ago only, I was out there just across the road, actually, having my daily walk in the park with the dogs, when I actually spotted a friend from a distance, of course, because we're still on lockdown and having our masks on even in the park. Well, I do anyway. And she recently bought a packet of Xylemelt. She has Schrögens. Have I said it right? Schrögens. Anyway, she was so excited. She almost ran up to me, and then remember, she wasn't supposed to come closer than 2 meters, is it? But she was so pleased to tell me, to show me actually her empty pocket, to say, look what's missing. Usually I could never go for a walk without that bottle of water in my mouth. But she said, I've got a Xylemelt stuck to my gum right now. And she said, they're just absolute. She said, it's just changed everything for me. And I was almost crying, actually. It's so lovely when we hear stories like that, because obviously she did have a big problem with a dry mouth. She's tried to fix it for years. Now, somebody put in the questions, I cannot believe those questions, Ari, thank you so much. I think after the last one, we had about 100 questions to reply to, didn't we? I've just lost where I was. That's it. Thank you. My script disappeared and it's disappeared again. Yeah. So one of the questions was, I can't get them to stick. Now, we've got to be honest here. There is a very, very small percentage of people who won't get them to stick because they have absolutely no moisture in the mouth at all. But that is only a very small minority of people. A lot of people, it's been a little bit impatient. expecting it to stick. And you know when you get them ulcers, them ulcers that really hurt. And you know when you keep putting your tongue to see if it still hurts? Well, it's a bit like that when you put a Zali melt in. I used to do it myself. I think, is it stuck? Oh, I don't know. I'll push a bit harder. And then it would come flying off. But also, the problem is, it's going too fast for me. And doing a Samantha, my script is flying over there, Samantha. Yeah, so it's not just about the stick, it's also finding the right place to stick it. So if you're new to Zali melts, you've never tried them before and you need to try them, I would always recommend you try them during the day. I mean, obviously there is expense involved, so you don't want to be using too many. But try it during the day first. And when you think, oh yeah, I've got the hang of this, then try it with your mask. Now, how close can they see me? Can they see me pretty close? I think so.
Go towards the camera.
Oh, if they go towards the camera. Now, not very ladylike, but can you see this gap here, right? That was not caused through dry mouth. That was through, well, something totally irrelevant, where I actually got an abscess and the tooth had to be removed before we went into lockdown. So I was actually thinking about having an implant, but I've decided, is it really worth it? But the problem was that was where my Zali melt used to go. So I had to find a new place. So here we go again. Now, so I'm going to try and show you. Now, so the first thing is that try to make sure that there is some moisture in your mouth. Okay. For some reason, I think you can stick them on the bottom, but I always go for the top. Make sure there's some moisture, just like licking your finger and running it across your gum, just to make sure there is some moisture there. For most of us, there is, but for people do have an even worse problem. You might just need to, I'll tell you what I did the other night, just only as an experiment. I used a gel, a dry mouth gel, which I'll show you in a minute. And I popped the gel, just a very light slither in. I was trying to imagine what it might be like for somebody who has no moisture. So I popped a little bit of gel in my mouth, and then I stuck the Zali melt to it. I have to say it worked, but I've only done it once. So, it's just something else to try. So we take out the Zali melt. So you can see there's a front, which is the white bit, and then there's the back. I can't, am I holding it up? Oh, there's my camera, that's why. Yes. So can you see how this is the bit that's going to stick? So literally, as I said to you, I lost my favourite bit, so I now go to the next tooth. Now, I asked Natalie, who's actually by my side, because she sometimes uses them herself, you said that you always only stick it to your gum, didn't you, Natalie? And for some reason, I always stick it so that it's slightly on my tooth as well. So it might be worth just, having a mess about. In your mouth, is it better just on the gum, or do you think just attaching it to the very tip of the tooth as well? So I'll try to show you so I'll look at that camera there, do I? So I'll try to show you. So all I do is I pop it in like that, and then I go like that to prise my finger off it, and then I completely forget it's there. If I start to wiggle, I'm going to disrupt its adhesive as it's trying to do its job to stick. So I haven't done a thing. So this is at the point where, I put it in my mouth, it's there now, but I will not allow my tongue to go anywhere near it. For me, I only use one Zali melt a night, and I choose to use a Zali melt because for the simple reason that I don't like too much humidity. So I'll lower my humidity a little bit, and have one Xylem. If I go away and I'm travelling on my own, say, to London, and I'm not the best traveller, I always get lost, don't I, and take too much luggage. So I often leave my humidifier behind. On those occasions, I will use 2 Xylem, but no humidifier. I do hear, though, one lady the other day told me she uses 4. Now, that is quite expensive, but the poor lady needs to. For me, it's just the one on that right-hand side. And by the way, that's stuck now. And I'm still talking to you. So it's a case of completely forgetting about it, you know. And then my mask goes on here, and that's where it is. And my mask is going to go along there. And the mask just seems to keep it in place as well. It's very, very rare that it might, you know, I'm not saying it's 100% perfect, by the way, because there will be the odd night where it will slip off, but I just crunch it and then put another one in, and I don't get any dry mouth that night. I just eat it as if it's sweet. Yeah, so anyway, I'm doing too much promotion here from the Xylem. I didn't actually mean to do it like that, but the reason I'm saying it is because people, have a look at the reviews, people say, you know, it's a game changer. It's changed everything. And that's why I really needed to, you know, mention it. So, like I said, do not be tempted to touch it with your tongue for at least 2 minutes. Just pretend it's not there. I'm carrying on talking, by the way, with it, and it's, you know, it's well stuck. So, added benefits of Xylem. It's the last thing I'm going to say about Xylem, and I promise you I'm not doing this for the sales, because anything we make anyway goes straight into the charity pot anyway, which is how we fund the charity, thankfully. But one other thing I am going to say, because I do think this one is important. If you suffer from acid reflux or GERD, as it was mentioned, was it Tony who asked the question earlier on? You may be interested to know a study was done using Xylem, which proved Xylem helped with acid reflux. And there's a link on our page. If you type in Xylem, remember beginning with X, you'll actually see a link to the study. And we do know this is true, because before we even knew about that study, people used to say, my reflux is a lot better, but we never realized it was linked to the Xylem. So that's just something else I thought, you know, would be worth saying. Now, there are other products as well, and they'll more than we know about, but a lot of you will know about the biotin. Can you see that? Okay, do I hold it there? Yeah, this is biotin. Now, we've already just added the biotin to the website, by the way, because we're so passionate in trying to get people not to have to go through tooth decay and gum disease, because if you any problem you get with your teeth or your gums, for a start, is going to affect your therapy as well. It's going to make, well, apart from your pocket, because dentists aren't cheap nowadays, are they? But it's going to cause a problem using your mouth if you've had an extraction or if you've had a filling or whatever. So the best thing, if we can keep our mouths in tip-top condition, it's going to help us, you know, in many ways. So the biotin. These actually only arrived yesterday. We can't give you any reviews, but we've just added them as another option. Now, last night I tried them and I thought, wow, I'm not sure if I like this. And then I read on the packet, 1 centimetre, and I put an inch there. So it was a little bit too much for me. It says it's unflavoured. If anybody has used biotin, by the way, please let us know in the comments, because we'd like to know what people think about it, because this one's new to us. So you can see it's just a gel, and you're supposed to just use 1 centimetre and then put it, was it in your tongue, on your tongue, and then just swill it about. Do you know, my mouth's going to be lovely after this, because I've got a Xylem here biotin gel on the left-hand side now. That's actually okay. You see, last night I put a massive dollop on. I actually, well, I felt a bit sick, put it that way. So anyway, that's something to try. And like you say, if anyone's tried them, please let us know in the comments so other people can read them. And obviously, you probably can get those in your local chemist anyway, but we've got it on the website, for convenience, if you did want to purchase it. Now, the other one, what's the other one? Oh, I've left it upstairs. Silly me. It's in my, it doesn't matter. Don't worry about going for it, Natalie. Thank you. I always forget something. The other one is what a lot of people may already have had from us at the website, from the website, is Bio Extra. So I can't hold that up, but it's BIO, then the word extra, XTRA. You can put a link out here, Natalie, if you've time. So Bio Extra, which is very, very similar to the biotin. It's again, it's another gel. You see, what works for one person will work better for another, and vice versa. So it's just another option, really. We've had good reviews on the Bio Extra, but as we know, what works for one doesn't always work for another. And the other new products, again, because of the dry mouth, and especially as we was talking about the mask mouth from face coverings. Now, this is something that I thought would be very handy. If you wake up and you've used the Xalimel, or you've used the biotin, or you've used Bio Extra, or anything else what you found in your own chemist, and you still, it might work for 4 hours, 5, 6, everybody's different. I quite like this idea. This one here, quick spray, not on the hand, obviously, quick spray. Now that is very, very easy. A quick solution that you might just want to use as a top up when the effects have run out of what you do use each night. And I just thought that's handy to put in your pocket for a quick relief, and I actually quite like that. So that's called, what's that called? That's called, oh, that's Bio Extra as well. Can you see it? That's Bio Extra, but it's the spray form. It's a gel spray, by the way. Now, one thing, just as I'm moving away from these gels and sprays, that I have to say, because in the other room we've got 2 Labradors, and a lot of you know we sadly lost one of our precious girls in September. Nothing to do with this, by the way, but I'm meaning that we're real dog lovers, and all those products contain xylitol. Xylitol is dangerous for dogs and can kill. So if you have a dog, I don't think it's the same for cats. You may want to look that up yourselves. I think it's just dogs that they are poisonous and can kill. So you must always keep anything with xylitol, and also check your own cupboards, because sometimes peanut butter has xylitol in it. Not all peanut butter, I mean some. And I think there's some yogurts with xylitol in it. Xylitol is very, very safe for humans. There's no known intolerances, but there is for dogs. And it's only the same as grapes. Grapes are really healthy, but don't let your dogs have grapes. My friend lost her dog and it only had a handful of grapes. So I just got to say that xylitol is dangerous for dogs. So moving on, stay hydrated with water. We mustn't forget that, must we? And apparently I'm told it doesn't count if it's in tea or coffee, which is a shame. And you can see, by the way, it's well stuck, this Xalimel. It's not moved because I'm still talking away. So I'm certainly not going to have a dry mouth at the end of this talk. So yeah, don't forget to dehydrate. It's, if you want, you know, have a cup by the side of your bed, because you know, if you want a little sip, you know, if you don't want to use the gels or sprays or whatever. But one thing I just would recommend, if you're using a mask, I have like a mason cup, I do. So it's like plasticky. It looks glass, but it's plasticky. It's got a screw lid and it's got a straw in the top. And I always think that's better, because if you're like me, I'm clumsy and I'd be knocking the water over onto the machine. And not only that, as well, is if, you know, on the rare occasion, I don't usually have dry mouth because I've got all the fixes, but on the rare occasion, I do like water though before I put my mask on. I always like a nice glass of water. But if you're, you know, you've got your mask on, you've woke up, you could just do with that little sip, just, you know, get the bottom of the mask and use the straw, so you're not actually having to take the mask off. Only a little sip there, just enough to wet your mouth, otherwise you'll be waking up next for the bathroom. So yes, we mustn't forget water, and also water for the skin, because another problem that we get, people waking up with marks on the faces from the masks, from the straps, and again, you know, you need to have good hydration, so lots of water for that as well. So I best move on quickly, because it looks like we're in the last 15 minutes. So curing mask leaks, again, not going to talk about that in depth, because there's well, that we can do that on another webinar anyway, but you'll see under the help section there's a whole page on mask leaks, and there can be many reasons for mask leaks, which is why it's a whole new subject, a whole subject of itself. So just the three most common things is quick fix. A lot of you know already about the silent night mask liners. They're, you know, you can make liners if you're clever. I'm not. You know, a liner might just be what you need, or at least till you get things fixed. A lot of people use liners anyway. I do, because we prefer the feel of the liner against our faces. But, you know, to cure quick leaks, because leaks will cause dry mouth. Ensure the mask is a good fit. Again, you know, have a look on the website, and we can talk about that another day. And also make sure you're not using a nasal mask and mouth breathing, because that, it will definitely not just compromise your therapy, because you won't get the full pressure from the machine, so you're wearing it for only a little bit of benefit, but it's, you know, it will cause you a dry mouth. Nose breathing is my next topic. The proverb: the nose is for breathing, the mouth is for eating. If only, but it's true. If it was that easy, ear, nose and throat consultants wouldn't be as busy as they were. And yes, there are many people who can retrain themselves to nose breathe, but it's not physically possible for everyone. So please don't believe those articles that says it's possible for everyone. It is not. I have undergone a sleep endoscopy, and which has proven, you know, the physical obstructions, I'll never be able to breathe. You can probably hear I'm quite nasally anyway, and that's despite 2 surgeries that have improved things. And I can nose, you know, I make a conscious effort to nose breathe during the day, but I can't always do it when I'm asleep. And, you know, so the, you know, the manufacturers wouldn't spend all this time working on these super duper masks that they're bringing out if everyone could just use a nose mask. You know, it's never that simple. One thing I will say, and you'll read again, tape your mouth up. Please don't tape your mouth up. How many people, if you could see Natalie, she's nodding here. How many times, how many calls have we got, Natalie? Have you lost count of the number of people who've rung us up and we've gone over, why are they getting headache? Why are they struggling like this? What happens? Oh, well, actually, I've been mouth taping. Oh, really? Really? Right, stop that. Then they'll ring up. No, you're right. What if you've got nasal obstructions and you know, put in your mouth so that there's you know, it's impossible to breathe. What you're going to do, you're going to retain CO2. Now, don't get me wrong, there are people, probably a bigger percentage, who could do that and there would be no problem. But Samantha, you know, if I could see her at the minute, I think she'd be nodding her head. It's not something we would ever, well, we won't, don't allow it in the group. Nobody will hear from Hope2Sleep that, you know, that they've been told to take the mouth closed, even though we are aware it will help a lot of people, but it can also work against and be dangerous for certain people. There are other ways to do this. Some of you will have already tried the Sleep Seal, which we are desperate for them to get ready for sale, because they are proving brilliant. We have seen similar things, but the Sleep Seal, they've got proper valves for different types of breathing. You can see them on the website and you can even request a sample. We do have some samples, but they're not ready for sale yet. And we have a lot of people waiting for them. And they are a safe way. And if you know, if you look, well, actually, if you go on to Sleep Seal's own website rather than ours, you'll see there's 3 different types. I think it's called www.sleepseal.net, I think, but it's definitely Sleep Seal, sleep and then SEAL. Have a look and you'll see what I mean. But please, you know, don't use just tape. Nasal strips, that's going to help you. We have the Snore Easy brand on our website, and we've chosen them because they're latex free. Most of the sleep strips are not latex free, so you can end up with allergies while trying to open. So the nose strips, what you see sportsmen wear, which I haven't got in front of me, and you put it on your nose and it expands, you know, as you pop it out. I should have brought one, shouldn't I? You stick it to your nose, you let go, and it springs and it opens your airways a bit. They're really helpful, and again with face coverings during the day. You know, again, you know, I sometimes struggle nose breathing in a face covering, so I've been using the nasal strips. There are also nasal cones and dilators. Those we don't have any, but you know that you'll find them easy on the web, on the internet, I should say. Just be careful though, because there's a lot of cheap and nasty ones out there. You know, look for something very hygienic, but they're worth a try. So they're nasal cones and dilators. Chin straps. There's lots of chin straps that can be used with or without masks. Just be very careful though with chin straps, because sometimes people will put the chin strap on and it will end up pushing the jaw back, which is defeating the object. You've got to make sure it lifts the jaw up. So we've actually just received some new ones from the States. But we won't talk about them until we've given them a really good test, but they do look quite interesting. My favourite, and a lot of people's favourites, is the Dr. Dakota neck cushion. Now, I prefer these to chin straps myself, and I know a lot of people do who are already using them. I don't want to get anyone excited though, because we can't get them at the moment. The problem being is because new ones are coming out, and COVID has slowed production down, so the manufacturer themselves don't have any. I'm going to be interested to see what the improvements are going to be, because it was fairly good as it was, but I'll show you. So instead of the chin strap, have I got that right way? I haven't I? Yeah. So can you see, this is the large. This is the problem with these. Most people are large, actually, even smaller people, because it's about the length of your neck rather than the width. So can you see how putting that on, now I know I'm sat up, so gravity is different, but can you see, if I'll be quiet just for 1 second, and I'll try to move and you'll see what I mean. So it's giving me gentle, I can talk because I'm talking now, but it's giving me gentle support and it's keeping it upright. It's the opposite of what you see on the flights. You know, if you think about it, when you put them around your neck, what's it doing? It's pushing your neck down. Not awfully the best idea. This is working the other way, keeping your jaw up. These are great, by the way, for planes or on coach trips or anywhere where you can't take your CPAP mask with you, but you might fall asleep and you might start snoring. Well, you're not likely to in this. That's me trying to snore. But my mouth, but not with this on. You say. So we can't wait for these to be ready, so keep an eye on the website. I know I'm going to rush in. I'm not even looking across at Tim because I think he'll say to me, come on, Kath, it's time you finished. So, and it is time I finished. Thank you, Harry, though, for keeping up with the questions, which has helped. So the obvious reason for dry mouth at night still needs including. There are many, many products on the market, but just be careful because there's a lot of gimmicks promising all sorts of cures. Sadly, some even mentioning that they'll cure sleep apnea. Please don't believe them because most of them won't. And if they did, if they would, I promise we'd tell you. We'd pack the charity in and retire because it'd be a lot easier. That I don't think is going to happen in our lifetime. There are reputable ones like the Zeus, which the manufacturer will be speaking on a webinar about that, and I will not elaborate now and let him talk to you all at a later date because trials are happening. Another reputable FDA-approved device is the Excite OSA, which a lot of you are already trialing, and so we're excited to hear about that. But what we always stress though, if you're a regular snorer, please, please always make sure you get checked out thoroughly. Ideally by having a sleep study to ensure the snoring isn't a warning signal for undiagnosed obstructive sleep apnea, because if untreated, you know, I'm talking to the converted here, it can cause and exacerbate lots of other medical conditions. You can see the full signs and symptoms of sleep apnea on our website. If you're having trouble getting a referral to a sleep clinic, we even do sleep studies at the charity. But I can't finish without saying, please, please never ignore regular snoring, just in case it's sleep apnea, because there's nothing that saddens us enough. And a lot of you know, I lost my own mother to a heart attack when she was 49, but it's so sad when we hear people who have had a heart attack or a stroke and then discover afterwards they were living with undiagnosed, untreated sleep apnea. Thanks, everybody. And thanks ever so much to Tim, to Samantha, and to Harry, giving up the time to do, you know, to put this on tonight. And we've had a few laughs as well, looking at Harry, who, what was it? My son messaged and he said, it's like the Grim Reaper, because Harry, when you see a playback, you're going to laugh. But absolutely fabulous talk. And thank you very much for that, Harry. And the same for you, Samantha. And with that distraction going along, I think I'd have walked out. So thanks, everybody.
You've just done the thank you on my behalf. I was just going to say,
Sorry.
that's absolutely fine. I was just going to say, yeah, thank you so much for your time, Ari, and for just an absolute warrior typing answers to all those questions. Yeah. It's just absolutely invaluable. And the same with you, Sam, typing away, and also, despite the technical difficulties, the background to the devices and how you're coping on the front line. And Kath, I wasn't expecting you to be doing hands-on demonstrations and show everyone the inside of your mouth.
Please don't anybody pause on it, will you?
I shouldn't be surprised.
It won't be a pretty sight. And there's no one else still stuck, by the way.
There we go. That's proof of the pudding. So at just gone 9:30. I'd like to thank everyone for their time and their questions. This has been recorded, so we'll put this on YouTube next week, and we look forward to welcoming you to our next webinar.
And
Thank you very much, everyone.
And we will answer those few little questions as well that are left there.
Great.
Thank you, Tim.
Thank you, everyone. Good night.
Thank you. Bye, everyone.